Under the IAP Action Plan 2024-25, the National Treatment Guidelines or NTG shall be released on various pediatric emergencies, and this particular guideline is on drowning and submersion. The World Health Organization reports that drowning is a preventable public health issue. It claims around 40 lives every hour throughout the day. So it is a very serious issue. More than 90% of these deaths occur in low and middle income countries like ours. It is the third most significant cause of unintentional injuries worldwide. International data actually underestimates the mortality rates in high income countries, whereas data from low and middle income countries suggests a mortality which is 4 to 5 times the mortality rate calculated by the World Health Organization. It is defined as the process of experiencing respiratory impairment. This is important, from submersion or immersion in liquid. If there is no respiratory impairment, generally drowning is the term is not used. It is considered to be a rescue rather than drowning. There are two types of drowning. First is the non-fatal drowning, which occurs when the victim is rescued at any point of time during the process and thereby interrupting the progression of drowning process. The other is a fatal drowning, in which we lose the victim at any moment of the process. Use of phrases such as dry or wet drowning, near drowning and secondary drowning is incorrect. So actually these are the terms which had been used earlier. In dry drowning compared with wet drowning, water never reaches the lungs and instead may cause laryngospasms. Near drowning means a person almost died from not being able to breathe, that is by suffocating underwater. And secondary drowning actually implies the complications occurring secondary to aspiration of water. NTG also says that the Utstein template is a standardized method for documenting data about drowning resuscitation cases. So what is this Utstein template? The Utstein style is a set of guidelines for the uniform reporting of cardiac arrest for use in emergency medical services. An example of the same template I have put over here. Like this is how you can report in emergency medical services, how you can report cardiac arrest, like resuscitation attempt required or not, resuscitation attempted or not, location of arrest, then distribution of arrest, then arrest witnessed or monitored, not witnessed, CPR before emergency medical services arrival, etiology of cardiac arrest, so on and so forth. Non-fatal drowning categorization framework or NDCF has been given by the World Health Organization to classify the severity of respiratory impairment and second, morbidity in non-fatal drowning. So first, classifying the severity of respiratory impairment after the drowning process is stopped. This severity in respiratory impairment can be mild, it can be moderate, or it can be severe. Mild impairment in respiration means that the patient is breathing. He has involuntary distressed coughing, but he is fully alert at that time. Moderate impairment means the patient has some difficulty in breathing. He is disoriented, but he is conscious. Severe impairment means the patient is not breathing at all and is completely unconscious. The second is the categorization of the morbidity. This is based on any decline from the previous functional capacity at the time of measurement. So what is previous functional capacity? It includes person's cognitive, motor and psychological capacity before the event. So category A is no morbidity, that is no decline in previous functional capacity. Some morbidity means some decline, and severe morbidity means severe decline in cognitive or motor or psychological or more than one of these capacities of the patient compared to what it was before drowning. Now aspirating water into the lungs causes coughing as a reflex response. But in less than 2% of the cases, there may be laryngospasm, which is immediately terminated by the onset of hypoxia. Continuing aspiration of water can cause hypoxemia, leading to loss of consciousness and apnea within seconds to minutes if not rescued. Hypoxic cardiac arrest typically follows bradycardia and pulseless electrical activity in comparison with ventricular fibrillation or ventricular tachycardia, which are not the type of arrhythmias seen in drowning. Water in alveoli destroys and washes out surfactant, leading to acute lung injury, and it also disrupts the alveolar capillary membrane integrity and increases permeability and creates a clinical picture of localized or widespread pulmonary edema. Water aspiration of as little as 1 to 3 ml per kg can significantly disrupt pulmonary gas exchange and reduce compliance by around 10 to 40%, causing respiratory embarrassment. So, it is something which leads to non-cardiogenic pulmonary edema. So, this radiograph is basically of cardiogenic pulmonary edema. As you can clearly see, there is cardiomegaly if we calculate the CT ratio. But I have put this radiograph over here to tell you what pulmonary edema looks like in a chest X-ray. Now, the clinical practice guidelines given by the Royal Children's Hospital, Melbourne in 2020 have included how to assess a patient of drowning, and since this aspect was missing in these guidelines, I have included the same here, and these are the latest. On assessment, you have to take a history of 3 things. First is the timeline, second is the circumstances leading to drowning, and third is considering a medical cause for drowning. So you have to know the immersion time, time to and type of basic life support delivered, time to first respiratory effort, and details of the treatment used. Circumstances leading to drowning, one must consider inconsistencies in story and story incompatible with developmental age, and you must consider a medical cause for drowning in children who are competent swimmers. These medical causes can be seizures, hypoglycemia, arrhythmias and long QT syndrome, and intoxication. At the same time, you must also examine the patient to look for any evidence of hypoxic brain injury, evidence of respiratory compromise, and signs of trauma, particularly head and cervical spine trauma. So, the basic management comprises of careful history and examination, continuous vital monitoring, recording temperature. Cervical spine stabilization is required in patients who drown by generally diving. In them, there is a risk of destabilizing or injuring the cervical spine. You must dry the chest before using defibrillators and look for any external or internal injury. Passive rewarming is done by removing wet clothes, drying the patient, putting a warm blanket, and making the environment around the patient warm. Active rewarming is done if the core temperature falls to less than 30 degrees centigrade and is done by giving warm IV fluids up to 39 degrees centigrade and warm saline up to 42 degrees centigrade gastric or bladder lavage. If the child is conscious with no respiratory distress, you just have to do basic management, must consider doing an ECG and discharge the patient with safety advice for future. In case the child is conscious with respiratory distress, in that case you have to do basic management, but along with that you have to provide oxygen, ventilatory support, invasive or non-invasive, IV fluids preferably warm, rewarming active or passive needs to be done, and hemodynamic support needs to be given as per the requirement. One must consider performing the following investigations, which include a chest X-ray, ECG, CBC, LFT, electrolytes and arterial blood gas, and assess if the child needs admission in emergency room, ward or PICU. In case the child is unconscious or having cardiac arrest, you have to immediately intubate and ventilate the child, as we all know, put a nasogastric tube, secure an IV or intraosseous access, treat the shock with fluids and rewarm actively and passively. Perform chest X-ray, ECG, CBC, LFT, electrolytes, blood gas, blood glucose, and consider a CT head if the patient is unconscious. And shift the patient to PICU for further management. In a conscious child with no distress, low flow oxygen through a nasal cannula or a face mask may just be sufficient. But in case the child has distress, one may require to open the alveoli, because as it is, the alveoli are filled with fluids and they are injured. So you might need to open the alveoli, and for this purpose you may require high flow nasal cannula or non-invasive ventilatory support. An unconscious child will definitely need intubation support to protect the airway reflexes, and lung protective ventilation strategy should be used. That is, you must use low tidal volume and only optimum pressures, not more than that, because otherwise it may result in volume and barotrauma respectively. High PEEP may sometimes be required for the reason I've discussed earlier, that the alveoli are injured and filled with water, so you may require more PEEP to keep them open. If shock is present, give intravenous saline at the rate of 10 ml per kg, and don't just overload the intravascular space because the child is already edematous. You have to perform continuous hemodynamic monitoring, and better is point of care ultrasound monitoring if you have the facility. You must use echocardiography to monitor fluids. This is what I was saying just now, and inotropes early during the process of management of shock. Early myocardial dysfunction is known to occur in hypothermia. Correction of hypoxemia and fluid status will improve acidosis. There is no benefit of using long-term sodium bicarbonate. There is no benefit of using sodium bicarb to correct acidosis, and one must monitor electrolytes and correct any electrolyte disturbance which is present. What is not recommended is a routine use of prophylactic antibiotics, routine use of steroids and surfactant. All these three things are not required for management of patients with drowning. Gradual rewarming is essential for correction of hypothermia, and the aim is to raise body temperature by 0.5 degrees centigrade per hour till a target of 35 degrees centigrade temperature is reached. There have been certain changes in the advanced life support guidelines in hypothermia. First, if the core temperature is less than 30 degrees centigrade, defibrillation becomes less effective in hypothermic myocardium, so you must limit the attempts to less than 3 shocks. Do not use inotropes or antiarrhythmic agents, as this may precipitate arrhythmias in these patients. If the core temperature is somewhere between 30 to 35 degrees centigrade, you can double the dose interval of inotropic or antiarrhythmic drugs, for example epinephrine or norepinephrine. For associated injuries, do a complete physical examination and skeletal survey post stabilization. ECMO can be helpful in cases of severe hypothermia and cardiac arrest. If facilities are available with you, early ECMO should be initiated. If a child is conscious on arrival in the emergency room, then the prognosis is generally excellent, but in unconscious children, it is difficult to determine the prognosis. It is said that if children have had less than 6 minutes of drowning, then they have a better outcome compared to children who have more than 25 minutes of drowning, who have a poorer outcome. Normal and conscious children with no distress can be discharged after an observation period of 8 hours, while a child requiring ventilator hemodynamic support who needs to be shifted to an ICU has to be discharged later, obviously, after complete stabilization. In case you are asked references, these are the references which have been used by these guidelines, but of course you will be mentioning the reference of the IAP NTG, the national convener of whom is Dr. Arun Bansal. Thank you so much for a very patient listening and watching, and please do share the knowledge. Thank you and thanks a lot.